You turned your head on the pillow this morning. Suddenly, everything began spinning. The room, the ceiling, the floor, all of it moving at the same moment. Your first thought was stroke, and then, just as quickly as it began, it stopped. The scan came back clean. The doctor sent you home. Here's what they didn't have time to tell you. In the vast majority of situations, dizziness is not a catastrophe. It's a mechanical issue with a mechanical fix. And 3 specific exercises can genuinely shift things. Not someday, but starting this week. If you'd like clear, honest health information explained in plain language, subscribe and hit like. It helps more people find this channel, and the target is 300,000 subscribers. You're part of getting us there. Practical checklists and health posts go out on my Telegram channel. Scan the QR code that's on screen right now. Let's begin with the basics, because most people get this part wrong. Balance is not one thing. Your brain is running 3 separate input systems at the same time, and it's cross-checking all 3 constantly. When all 3 line up, you feel steady. When one of them sends the wrong signal or contradicts the others, your brain gets confused. That confusion is what you experience as dizziness. The first system is the vestibular apparatus. That means the inner ear, specifically the cochlea, 2 small pouches called the saccule and utricle, and 3 semicircular canals positioned at different angles. Those 3 canals cover 3 planes of space: horizontal, vertical, and lateral. That way, any movement of your head in any direction gets picked up. Inside those canals is a gel-like fluid called endolymph. Floating in that fluid are tiny crystals of calcium carbonate, known as otoliths. Picture them as grains of sand, smaller than a millimeter. When your head moves, the fluid shifts, the crystals press against specialized hair cells, and those cells fire a signal to the brain. Head moved, here's the direction. The second system is vision. Your eyes are sending a continuous feed of spatial information to the brain. Where the horizon sits, what's stationary, what's moving. This is why dizziness often gets worse in the dark. One input channel goes offline and the whole system becomes less stable. The third system is proprioception, your body's internal GPS. Receptors in your muscles, tendons, and joints, especially in your feet, calves, and neck, are constantly reporting your body position back to the brain. Close your eyes and raise your arm. You know exactly where it is without looking. That's proprioception doing its job. All 3 systems need to be in agreement. When they are, you feel grounded. When one misfires, the brain loses its footing. That's dizziness. Now let's talk about the most common type. It comes from the inner ear, and it has a name: BPPV. Benign paroxysmal positional vertigo. Each word tells you something useful. Benign means it's not a stroke, not a tumor, not structural brain damage. Paroxysmal means it arrives in sudden, sharp episodes. Fast start, fast stop. Positional means it's set off by movement, turning your head, lying down, rolling over, standing up. Here's what's happening mechanically. Those calcium crystals, the otoliths, are supposed to remain in their designated pouches. Sometimes they break loose and drift into one of the semicircular canals. Aging can cause this. So can a head injury. Extended bed rest can do it. Osteoporosis, a condition where bone density drops and calcium metabolism becomes unstable, raises the risk. Sometimes it happens for no clear reason at all. When a crystal ends up in the wrong canal, even a small head movement sends it rolling where it shouldn't go. The hair cells get hit with a powerful abnormal signal. The brain reads that signal as rapid, intense rotation, even though you barely moved. That's the spinning. That's the terror. And that's what resolves in under a minute once the crystal settles. Research consistently shows that BPPV accounts for more than 1/3 of all vertigo complaints seen in clinical settings. That's a huge proportion of people, and a meaningful number of them spend years being treated for the wrong thing entirely. Cervical spine problems, vascular issues, blood pressure disorders, all labeled and medicated, none of it actually fixing the real mechanical problem. There's a pattern that shows up in primary care records more often than people realize. A man in his mid-60s, call him David, wakes up one morning, turns toward the nightstand, and the room spins hard. He calls an ambulance. By the time the paramedics arrive, it's already stopped. The MRI shows nothing. He goes home with a diagnosis of vascular dystonia and a blood pressure medication he didn't need. 2 years later, a neurologist finally asks the right question, performs a repositioning maneuver, and the problem clears in 5 minutes. 2 years, 1 maneuver. How do you recognize BPPV in yourself? 5 signs. First, the dizziness has a direction. You feel the world spinning to the left or to the right, or you feel yourself falling toward one side. This is not general fogginess. It has a vector. Second, it's short, usually between a few seconds and 60 seconds. It stops by itself. Third, movement triggers it. Rolling over in bed, tilting your head back, standing up quickly. Fourth, nausea comes with it, sometimes vomiting. Fifth, after the episode ends, the fear sticks around long after the spinning has stopped. BPPV does not require medication. It requires repositioning. A neurologist or a vestibular specialist, a trained clinician who works specifically with balance disorders, can physically guide your head through a precise sequence of movements. The aim is to steer the displaced crystal back out of the canal and into the pouch where it belongs. The Epley maneuver and the Semont maneuver are the 2 main techniques. Both have strong evidence behind them. It's worth asking your doctor specifically whether BPPV has been ruled out, not as a side note, but as the actual primary question. Now, let's talk about the other type of dizziness, the kind that doesn't spin. No rotation, no clear direction. Instead, it's a constant sense of unsteadiness. Walking on a soft mattress, standing on a boat that won't stop rocking, a foggy, floaty feeling in the head. Some people say it feels like the world has a slight lag to it. Others describe feeling vaguely unreal, like they're watching themselves from a step behind. Technically, this is not vertigo in the medical sense, but people call it dizziness, doctors need to take it seriously, and the causes are multiple. Vitamin deficiency is one of the most commonly missed culprits. B12, cyanocobalamin, is critical for the myelin sheaths that insulate nerve fibers, including the fibers that carry vestibular signals. When B12 runs low, those sheaths thin out, signal conduction slows down, and the result is unsteadiness, imprecise walking, a sense of instability. This is especially common in people over 50, in vegetarians and vegans, and in people taking metformin long term. Metformin, one of the most widely prescribed medications for type 2 diabetes, is known to reduce B12 absorption in the gut. If you've been on metformin for years and nobody has checked your B12 recently, that's worth raising with your doctor at the next visit. Vitamin D deficiency also matters here. Research suggests that low vitamin D affects both neuromuscular function and the structural integrity of the otolith crystals, the very crystals that, when dislodged, cause BPPV. Multiple studies have looked at the link between low vitamin D and increased BPPV risk. Getting your B12 and vitamin D levels checked is a sensible, low-effort first step. Vision problems are another underappreciated cause. This sounds counterintuitive, but an ophthalmologist may be exactly the right specialist for someone with persistent dizziness. Ill-fitting glasses, early-stage glaucoma, or problems with eye muscle coordination all distort the visual input the brain uses to orient itself. When the visual signal is off, spatial orientation becomes unreliable, and the result is that persistent, floaty unsteadiness. Cardiovascular causes cover a wide range. Arrhythmias, irregular heart rhythms, can briefly cut blood flow to the brain, producing a momentary dizziness. Orthostatic hypotension. That's when your blood pressure drops sharply the second you stand up, causing a sudden darkening of vision and a wave of lightheadedness, is extremely common and often completely fixable. Atherosclerosis in the vessels supplying the cerebellum and brainstem, the posterior circulation, can lead to chronic balance impairment. All of these have specific tests and specific treatments. There are neurological causes that deserve mention. Multiple sclerosis can present with vestibular symptoms in its early stages. Transient ischemic attacks, brief, temporary interruptions of blood flow to the brain, can produce sudden onset dizziness that clears on its own but demands immediate evaluation. Tumors of the posterior cranial fossa are rare, but when a doctor is looking at unexplained dizziness, ruling them out is part of the process. The neck deserves its own conversation. Cervical spine problems are one of the most overdiagnosed causes of dizziness in clinical practice. It's a fashionable label. In reality, the neck muscles do contain proprioceptors, and when those muscles are in chronic spasm or dysfunction, the proprioceptive signal they send to the brain can become distorted, contributing to balance instability. That's real. But the idea that blood vessels get mechanically pinched by neck bones and cut off blood supply to the brain is far less common than the diagnosis suggests. If you've been told your dizziness is from your neck, it may be worth a second opinion. Vestibular migraine is a diagnosis that most people have never heard of. It's a form of migraine in which the headache takes a back seat, or doesn't appear at all, and the main symptom is intense dizziness. Episodes can run for hours. They're often paired with light sensitivity and nausea. Many people with vestibular migraine spend years being investigated for BPPV or vascular problems without anyone connecting it to migraine. If you have recurring episodes of severe dizziness that last hours and come with light sensitivity, that specific diagnosis is worth raising with a neurologist. Then there's the type of dizziness that no scan will ever find. It has a clinical name now, PPPD, persistent postural perceptual dizziness. Persistent means it's chronic, present most days. Postural means tied to body position and movement. Perceptual means it's about how movement is perceived, not about any structural lesion. Here's how it develops. A person goes through a real episode of BPPV, that terrifying, violent spinning. The body survives it. The scan is clear. The episode resolves. But the nervous system doesn't fully relax. The brain, which is fundamentally a prediction machine, learned that head movement is dangerous. Now it runs a permanent background scan of every motion, waiting for the threat to return. And that constant vigilance produces a continuous low-grade sensation of instability, even though nothing is structurally wrong. A well-documented pattern in balance medicine looks like this. A woman in her early 60s, call her Susan, has a single BPPV episode. It clears in a few days, but she starts to hold her head very still. She stops going to the grocery store because the movement of other shoppers feels disorienting. She stops riding in cars. She avoids crowds. She barely leaves the house. Months pass. Her balance hasn't gotten worse, but her world has shrunk to the size of her living room. And her dizziness is now driven by anxiety, not by anything in her ear. The treatment for PPPD is different from BPPV. It doesn't involve repositioning maneuvers. It involves working with anxiety, specifically cognitive behavioral therapy, which has solid evidence in this area. In some cases, SSRI antidepressants, selective serotonin reuptake inhibitors, are used as support. Prescribing an antidepressant for dizziness is not a mistake. It's the right treatment for a specific, real mechanism. All of this is worked through with a psychiatrist or psychologist, and the aim is to retrain the brain's threat response, not to medicate the ear. Alongside psychotherapy, vestibular rehabilitation exercises are used for both BPPV and PPPD. For BPPV, they retrain vestibular compensation. For PPPD, they systematically break down the fear of movement. The brain learns through repetition that movement is safe. That process is called desensitization. It takes weeks. It works. Let's walk through the 4 exercises now. Each one targets a specific aspect of balance and vestibular function. Exercise 1, gaze stabilization during head movement. Extend your arm in front of you. Raise one finger to eye level and fix your gaze on it. Now slowly turn your head left and right, but keep your eyes locked on the finger. The head moves. The eyes compensate. This is training the vestibulo-ocular reflex, the automatic mechanism that holds your vision steady during head movement. That reflex is one of the first things to degrade with vestibular dysfunction, and direct training is how you rebuild it. Begin with 2 or 3 turns in each direction. Move slowly, no jerking. If you feel mild dizziness during the exercise, that's expected, and it's exactly the signal that triggers adaptation. Don't stop because of mild discomfort. That discomfort is the training. Each week, add a couple of repetitions. You can do this seated at first, standing comes later. Exercise 2, gaze stabilization during object movement. This time, your head stays completely still. Hold a pen or pencil and move it slowly from side to side, tracking it with your eyes only. No head movement. This trains smooth pursuit, the eye's ability to follow a moving object without losing visual stability. Impairment in smooth pursuit is a recognized marker of vestibular dysfunction. Same progression. Begin at 2 or 3 repetitions, build up gradually. Stand near a wall in case you need to steady yourself. Exercise 3, single leg stance. This one trains all 3 balance systems at the same time: vestibular, visual, and proprioceptive. Stand upright. Lift 1 foot off the floor, knee bent. Arms out to the sides. Hold for 3 seconds. Swap legs. Work up to 30 seconds per side. Once that becomes solid, close your eyes. The moment you do, you'll understand why this is a serious exercise. Without visual input, the brain falls back entirely on the inner ear and proprioception. Train near a wall. Exercise 4, positional training. This one works directly on both BPPV and the fear of movement. Sit in the middle of your bed with pillows on both sides. Turn your head 45 degrees to one side. Slowly lie down on that same side, keeping the head angle. Place a pillow or rolled towel under your head to hold the angle. Stay there for 30 seconds. Dizziness may begin. Let it. This is deliberate, controlled vestibular activation. Exactly what trains the system to adapt. After 30 seconds, slowly return upright. Pause. Repeat to the other side. 3 full cycles each direction. No rushing. This exercise requires at minimum 2 to 3 weeks of consistent daily practice. For some people, it takes 2 to 3 months. That is not failure. That is how neural adaptation works. The brain doesn't update in a day. The evidence base for vestibular rehabilitation is substantial. Large systematic reviews covering thousands of patients show that regular balance exercise significantly reduces dizziness severity, improves postural stability, and lowers fall risk. This last point matters enormously. Multiple studies have shown that fall risk climbs with age as all 3 balance systems become less precise. The vestibular apparatus loses sensitivity, proprioception becomes less accurate, vision deteriorates. Regular balance training is not optional upkeep after 50. It is a direct intervention against one of the most serious causes of injury and disability in older adults. After 45, the risk of BPPV climbs noticeably. The otolith crystals become less mechanically stable as calcium metabolism changes with age. Leave a comment with your age. I genuinely want to know how this topic lands across the channel's audience and whether a dedicated episode focused on balance in people over 60 would be worth making. Before wrapping up, a critical note about red flags. Most dizziness is not dangerous, but some is, and you need to know the difference. If dizziness shows up alongside slurred speech, weakness in one arm or leg, sudden loss of vision, severe loss of coordination, or a headache unlike any you've had before, that is a medical emergency. Call 911, do not wait to see if it passes. These are possible signs of stroke, and time is the single most important variable in how that story ends. For the vast majority of people, dizziness comes down to one of 3 things: a displaced inner ear crystal that responds to repositioning, a systemic cause like vitamin deficiency or a cardiovascular issue that has a specific addressable fix, or a nervous system stuck in threat mode that responds to behavioral and rehabilitative work. All 3 are treatable. None of them require years of medication that doesn't address the real problem. What you can do starting now: write down whether your dizziness has a direction and a trigger, or whether it's a constant fog. That distinction alone shapes which direction you need to go. Bring that description to your next appointment. Ask your doctor to specifically check your B12 and vitamin D levels. Ask whether BPPV has been ruled out. Start the gaze stabilization exercises today. They carry no risk, they require no equipment, and the evidence that they help is solid. Use the single leg stance exercise daily, near a wall. The information in this video is for educational purposes only. Before acting on anything here, please discuss it with a qualified healthcare provider who knows your individual history. If this gave you something worth knowing, subscribe and hit like. That's how this channel reaches more people, and 300,000 subscribers is the target. Scan the QR code on screen now to find my Telegram channel. That's where checklists and practical health posts go out regularly, and it's worth keeping nearby.